I will invite my good colleague from Denmark, Lone Skov. She's professor at University of Copenhagen, to talk about biomarkers in psoriasis treatment today and in the future. Please, Lone.
Thank you. Thank you, Lars, for the nice introduction and to giving me the opportunity to talk about biomarkers here today. And first of all, my disclosures, and then the agenda. I will talk a little bit about, in general, on biomarkers. How are we today, and what is the biomarkers for psoriasis in the future? And biomarkers has really been a subject who has come into the knowledge in the last 50 years, and especially in the last 20 years. And there's a lot of different definitions on biomarkers. The World Health Organization introduced one definition in 2001, saying that any substance, structure, or process that can be measured in the body or in its products and influence or predict the incidence of outcome or disease. FDA have their own, more related to treatment, and they defined biomarkers as a defined characteristic that is measured as an indicator of normal biologic processes, pathogen processes, or responses to an exposure or an intervention. But all this interest on biomarkers is really just because we try to get a step closer to use a more personalized medicine. And we actually already use a lot of biomarkers in our daily clinic. We know that high level of cholesterol is a marker of atherosclerosis and a risk factor for heart disease and stroke. We know that a high level of prostata-specific antigen is a risk factor for prostate cancer, or more for treatment. HER2 positive cell is a marker of a more severe outcome of mama cancer, and also an indicator for that this patient could be treated with Herceptin. And there's a lot of different biomarkers. The two main groups is diagnostic biomarkers, but there's also monitor biomarkers related to use of drug. And then people have tried to really classify the different type of biomarkers as predictive or prognostic. But overall, what we want is an ideal biomarker is that it should be easy to measure, it should be reproducible and cost-effective and easy to test in body fluids or as serum, salts, urine, or in the skin. And of course, the ideal biomarker will have 100% sensitivity and specificity, which we probably will not reach. And then for biomarkers in relation to psoriasis, if you just make a search on Web of Science and look for publication with biomarkers and psoriasis, it's really in the last 10 years there's been interest and coming a lot of publication out, and it's increasing, and it's mainly in dermatological journals, but also journals in immunology, biochemistry, molecular biology, and of course rheumatology. And what is the biomarkers looking or trying to predict? It's the diagnosis, and it's especially for psoriasis. The subtype of psoriasis is the disease trajectories, who will have the more severe disease and maybe should be treated early on, who will have the risk for comorbidities, who will get psoriasis arthritis, and then, of course, response to treatment. And how is it then today? I'm so lucky that there has in this spring been published 2 large reviews in British Journal of Dermatology, 2 scooping reviews, which is more broad reviews, not like systematic reviews looking more over the whole area of biomarkers. And there were the two, one looking at biomarkers for disease progression, especially disease severity and the risk of comorbidities, and the other one looking at response to systemic treatment, treatment outcome, and also adverse effects. The study was done by the Biomarkers Consortium. It's a consortium for biomarkers in atopic dermatitis and psoriasis, led by Kathleen Smith in London. And we try to find all studies with more than 15 patients with psoriasis. And unfortunately, the results was that there at the moment is no biomarker that is supported sufficient to be used for clinical practice without further evaluation. But that does not mean that there's a lot of candidate biomarker which could be, when we have more data, be used in the clinic. And to look a little bit more into the two reviews, the reviews on disease progression identified 181 studies, mainly on disease severity and 13 on psoriasis arthritis. And as you can see, for the candidate genes, which is here, there's a lot of genes identified which could be, or a lot of candidate biomarkers identified which could, when we have more data, be used. And most of the biomarkers is related to the immune system, more than 50% as indicated with the blue over here. For the biomarkers for response to systemic treatment, most of the biomarkers were related to genetics or proteomics studies, and there was in total identified 71 studies, mainly on the treatment outcome, but also of the treatment safety. And from these studies, there was some candidate genes related to CARD14, IL-1 beta, and HLA-CW6, and related to treatment response, especially for TNF-alpha and ustekinumab, or the IL-12, IL-23 pathway. So there's a lot of candidate genes, but no one really to use in the clinic at the moment. And it's not because there's not big studies looking on biomarkers. There's several large studies looking at one of the really candidate biomarkers, the HLA-CW6, and this Jonathan has already shown that it could be used as an indicator for response to treatment. It has been shown that it indicates if you are positive, you have a greater risk for responding on IL-12, IL-23 pathways. And here, in a large group with more than 1,000 patients from London, they show that if you are negative for the allele, you have a lower or higher risk of responding, and I have a PASI 19 on adalimumab. Also, they have, again, in UK, looking at much larger group, two large cohorts with more than 90,000 patients in total. Again, look at the HLA-CW6 and look whether they could relate it to risk of comorbidities. And it was actually shown that the patient which were negative for HLA-CW6 have a higher increase of risk factors for cardiovascular disease, as shown here for hypertension, but also for abdominal obesity. Then, of course, there is a lot of small studies looking at also response to treatment, and I will just take one of ours in, looking at baseline cytokine level as indicator for patient response to treatment. And there's some indication that if you have a low level of TNF-alpha or IL-6 before starting treatment, you have a higher degree of response, and here it was shown for brodalumab, but we also did it in a little bit larger study with patients starting on adalimumab, and we could show that patients with a low baseline level of IL-6 have a higher degree of response on TNF-alpha treatment. So I would expect in the future that we will get a lot of new biomarkers or a lot of validated biomarkers that we also can use in the clinic. And what do we really want to have a data from the biomarkers in the future? Yeah, the Biomarkers Consortium have also done a study. They have done a Delphi survey trying to find the best markers for a good biomarker. And what they think that people should focus on is the performance, the clinical validity, the relevance, and the positive predictive value. But again, the purpose, as we have heard already several times during the former presentation, that we should have indicator for good treatment response, but also for disease progression and risk of comorbidities, so we know if we can treat the patient earlier on, which should we treat, and then all the studies need to be more validated than at the moment. So for the future for biomarkers in psoriasis, yeah, it's still in the early stage. There's several different candidates that has been identified, but really no one to use in the daily clinics before we have more studies. And it's likely that we won't have one candidate, but we'll need to have a group of biomarkers to identify the best treatment outcome. Thank you.